So welcome to Canine Addison's Resources and Education interview and webinar with Canine Addison's researcher, Dr. Daniel Langlois. And I will ask him to introduce himself in a little bit. First, I will tell you a little bit about CARE. We call it CARE for short. CARE is a nonprofit organization based in the United States, but we have an international board of directors. So we have folks from currently from Wales and Germany and the Netherlands and the US right now. And we have volunteers from all over the world. We have a website which has a ton of information on it, canineaddisons.org. If you go there, our documents page has a ton of, has everything you ever want to know about Addison's, and we keep adding more. We have a Facebook group in which we help people really day and night, all throughout every time zone. We are at getting close to 7,000 people in the Facebook group, so it really has grown. We started our organization in October of 2013. So in that time, it has really grown. We also, our website has documents that are translated into many languages. We have Canine Addison's brochures that we distribute throughout the world in many languages. We distribute them at no cost. Usually we give them to vets, put them in stores and doggy daycares and wherever we can find a place that people would want them. We also do what is called Canine Addison's Awareness Week, and that will be February 20th this coming year, 2022. And we do a ton of stuff there. We try and really spread the word about Addison so that no dog has to suffer because the vets don't always know to look for it. And I believe we have one of our board members is here today, Megan. Megan, are you able to introduce yourself?
Hi, sure. Sorry, it's dark. I wasn't planning on speaking. I'm Megan Schultz. I live in Missoula, Montana, and my dog Luke was diagnosed early in 2016 when I was pregnant with my first kiddo. And he is now 9 and doing awesome. And I've been involved in Awareness Week, where we do lots of different things. I've spoken on our local news to get the word out, as well as done fundraisers here locally. And sorry, my daughter's home today. You can hear Scarlett talking. But yeah, have enjoyed being a part of CARE, and it's wonderful. We have brochures all over our town, but when we did the news story, it was broadcast all over the state of Montana. We got some new members there, recommended many people to my local vet. So just really enjoy being a part of CARE.
Thank you. And we have, again, I wish I could give time for everybody to introduce themselves, but we can't, but we can take time afterwards. So this is what we're going to focus on today: welcome and introductions, and then we're going to go through our agenda. We're going to talk about recognizing Addison's in lab results. We're going to talk about diagnosis, including possible alternative options for diagnosing. We're going to talk about Dr. Langlois' research findings and the long-term management with a focus on DOCP, and hopefully we will have time for participant questions. And having told you the agenda, I am going to ask Dr. Langlois to introduce himself. And Dr. Langlois, if you could just tell us a little bit about your background, what you study, what makes you interested in those things.
Yeah, sure. Thanks a lot for having me. I appreciate it. Obviously, I have a strong interest in Addison's disease. I did veterinary school in Louisiana, so I did my undergrad in vet school at LSU. I made a brief pit stop at Ohio State for an internship. I came to Michigan State for residency training, and I've been here as faculty for the last almost 9 years now. And so my interest in endocrinology probably started during my residency. I don't most of you are probably less familiar with this, but Michigan State has the largest endocrinology laboratory, really in the, not just the United States, but everywhere. We have a really, really large endocrine lab. And we also have a really, really high endocrine caseload. So we see lots of endocrine diseases, not just Addison's, but lots of them in general. And one of my mentors was one of the original Addison's researchers back in the 1980s. And so I sort of got interested because of some of the work that he had done. In fact, he was one of the original ones to describe Addison's in a large number of dogs. He was also one of the original ones to describe whipworms mimicking Addison's disease. I don't know if some of you have heard of that or not, but certainly sometimes intestinal parasites can result in really, really similar clinical and laboratory findings. And so my interest kind of followed his. And then after he retired, I became section head, and I devote a lot of my research efforts to Addison's disease, and partly because of his interest that spurred my interest, but at the same time, it's one of the few diseases I treat as an internist that our patients usually do fantastic for a long number of years. And we deal with a lot of really bad diseases, and Addison's is certainly a bad disease, but also a very treatable disease. And so our team, which is clinicians, diagnosticians, a variety of backgrounds, have tackled a number of, I guess, issues or topics relevant to Addison's disease in the past, 5 to 10 years. And so, and I think that's kind of what we were going to touch upon and go through there. So yeah, thanks again for having me.
Great. I really appreciate that you're doing this. Almost the great majority of people in our Facebook group are using DOCP. We do have some people who still use Florinef, but the great majority use DOCP. And we talk all the time about your research and others as well. And I really appreciate you being here. You mentioned your mentor, but you didn't say what his name was. Do you want to?
Let's say Dr. Bill Shaw or William Shaw. And so he was one of the original ones. And he used to walk around our clinic floor, and his dosing schematic for DOCP was 0.5 ml for little dogs and 1 ml for big dogs. And so I think, a lot of us aren't quite that bold, but that was his saying that he used to have. And so we've been modifying DOCP dosages for long before I ever even arrived at Michigan State.
I had heard that. And then I heard that some residents were scared to do that little. So they might give a little bit more to a big dog. But
yeah, we see that a lot. And I think a lot of people still have the comfort zone of administering label dosages. So certainly there is some fear, but I think once people shift away from that, they get more comfortable with it.
Right. Okay, so let's move right along so that we can cover everything we wanted to cover. You had mentioned that you wanted to talk a little bit about just recognizing Addison's in the blood work and how difficult that can sometimes be.
Yeah, sure. And I'll share my screen now. At least I should be able to. Let's see. I think everybody can see my screen, hopefully.
Yeah. And if you make it a slideshow.
Yep.
There you go.
Let's remove my bar so I can see. Yeah, and so we can kind of breeze through different aspects, and I have a lot of different slides so we can touch upon as we go through. But I know most of you mentioned disease awareness, or I heard you saying that, trying to raise disease awareness. And I think, part of the challenge is that, people are often taught young to middle-aged, purebred, female spayed dogs. And that's absolutely true. We see those types of heightened risks, but the information that we've accumulated over the years is we've diagnosed dogs with Addison's disease as young as 3 months of age and as old as, we actually had one that was 14 years of age. So I should actually change that number now. But this is Ziggy. He is our youngest Addison's patient that we've had in our hospital. He was 3 months old at the time of diagnosis. We all thought for sure he was going to have some other disease, but nope, he just had run-of-the-mill Addison's disease. The female predispositions also overstated as well. There is a slight female predisposition, but probably not the 70 to 80% that was once cited decades ago. And certainly we do see it in more spayed and neutered pets. But again, that's also the general pet population that we're dealing with, at least many of us are in our settings. And purebred dogs, certainly more common as well, but about 30% of the cases of Addison's disease that we diagnose are in various mixed breed dogs as well. And so I really do think that it runs the entire gamut from young to old, young to old, male to female, any dog can really be affected. And so I think it's sometimes important for veterinarians to get that sort of dogmatic approach out of their mind when considering what cases might actually be affected with Addison's disease. And I was going to show, and these are all real cases. So we treat about 25 to 30 new cases a year at our hospital. And part of that is because we're the main ER and referral service in the area. So I think we get most of those dogs through our emergency service, but we do have a really high caseload. And so we have a lot of experience with diagnosing these dogs on a new case basis, but also following up these dogs for a number of years. And so here are just a few, these are real life cases. These are all cases that have presented to us, just kind of show you the examples of why it can be confusing to recognize and the different types of presentations that we see. And the first case I was going to share with you was a dog that was seen by our emergency service. And Dr. Matt Beals, the head of our ER group, and at the time we were doing one of our Addison studies, and he came to me and said, "Hey, I've got the perfect dog for you. It's this 9-month-old female intact mixed breed dog." This dog had known ectopic ureters, so this dog just leaked urine all the time, but that's not why it came in. It came in because it had been really sick for the past few days. The last few days, the dog had been completely anorectic, not eating anything, extremely weak. And so we ran some blood work, and we won't go through all of the findings. But the reason that the emergency room came sort of running to us saying, "Hey, we think we have a patient for your study," as the dog had a sodium of 120, a chloride of 90, and a potassium that was really high at 7.5. And so sort of those classic findings of really low sodium, really high potassium, many of those classic laboratory features. Urine analysis was a mess. We won't even look at that. But when we actually tested this dog for Addison's, it was very normal. This was not an Addisonian. In fact, this dog actually had a kidney infection and whipworm infection. So the dog had 2 comorbidities or 2 other conditions that can look very much like Addison's. And so I think, again, this highlights why it's sometimes hard to say what is and what isn't Addison's. Our emergency group was willing to bet this dog was an Addisonian. On the other hand, another case that we saw at similar time, similar presentation, a little bit older of a dog, but again, a very sick, weak dog. It had been sick for several weeks and then had really acutely worsened in the recent days. And this dog, again, very similar blood work. There were some differences along the way, but if you look at it, the sodium and chloride and potassium almost identical to the dog in the previous case. And sure enough, when we tested this dog for Addison's, there was virtually no cortisol. And so this was a very classic Addisonian. But I think from the awareness standpoint, there's a lot of other diseases that can look like Addison. So we always think that Addison's looks like other diseases, but there's other diseases that look like Addison's disease as well. And so I think this only complicates recognizing it in a clinical setting. And so, and I should mention too, Lori, if any of y'all have questions along the way, just stop me or ask them in the chat, and I'm happy to kind of, pause along the way as well. So don't hesitate to stop me. This was another case. This case came through our primary care service, so just our general wellness service that we run out of our hospital. And they came in basically because this dog had a hot spot on its back end. But in the course of the history, they had mentioned that after one of the housemates had been euthanized a month earlier for some longstanding issues, the dog had just been, they said it was psychologically or emotionally depressed. They thought it was sad because of the loss of the littermate, and quite possibly it was. But what they had noticed is that this dog was grazing. So rather than being a meal eater that would, this dog normally would ravenously eat its food, now it would just sort of pick at its food throughout the day. And so our primary care service was going to start it on a short course of steroids because of the hot spot, but they figured they would run some blood work before they did that. And so, again, we're not going to go through all of the findings. That's beyond the point of this, but there were some clues. The potassium in this dog was ever so mildly increased. It was 5.2. The upper end of normal is 5.1. The sodium was actually within our normal reference interval. It was at 142. And again, this was a dog that was honestly not very sick. It came in for a hot spot, nothing else. Sure enough, this dog had absolutely no cortisol. And so again, I think We look for these cases because we see a lot of them. We have research programs focused on them, but it's really easy to miss some of these really subtle cases of Addison's disease in dogs. I'm going to skip. I'm sorry, go ahead, Lori.
If I can just stop you for 1 second on that. What we've seen lately is a number of dogs who have really low sodium and normal potassium, and it does confuse us because it's like, wait a minute, this doesn't look like what we normally see, but they have Addison. So I'm really glad that you pointed that out.
Yeah, and we see that in both directions. We'll see dogs with the normal sodiums, but the high potassiums, the normal potassiums versus the low sodiums. And it's hard to say which one do you focus on. I think it's not that you're focusing on one or the other or the ratio. You're looking at every one of those. A high potassium is important. A low sodium is important. The ratio is important. But we'll come to it in a little bit. And some of you probably have dogs. I don't know if any of you had dogs that were diagnosed and their electrolytes were actually both normal. We see that as well quite frequently. And so, the electrolytes are one piece of the puzzle, but by no means are they the entire puzzle.
When you see results like this that aren't low sodium, high potassium, do you test aldosterone or no?
So we do, and I'll circle back to that in just a minute, but we absolutely do. But the other thing that from our standpoint as doctors is, we can't only look for the signs of aldosterone deficiency. Aldosterone is what's controlling those electrolytes, but cortisol is controlling a lot of those other things. And so the high calcium, that can be caused by a lot of things, but Addison's disease is one of them, and that's a cortisol mediated effect. If we actually look at this dog's blood count, many of you are probably familiar with the saying that they can't develop a stress response, right? Because they don't have cortisol. And typically dogs that are stressed have low lymphocyte counts. This dog had a high lymphocyte count. And so in the dogs where the electrolytes aren't classic, oftentimes there's other clues, but they're the clues that are a little bit less common and the clues that are easier to overlook in some of these cases. So I'm going to skip that case, but this was a case that I'll always remember because the owner of this dog was a young college student and she was just the most non-compliant owner ever. It was this constant issue, but she owned a Great Dane, which was probably not the ideal dog for a 19 or 20-year-old freshman or sophomore in college. And this Great Dane's name was Harlow, actually. And Harlow had been seen through our emergency service 3 times for pneumonia. The dog would occasionally regurgitate and then would sometimes aspirate that and develop pneumonia. And they actually did some studies and documented that the dog's motility in its esophagus, the ability for this dog to move food from his mouth into his stomach, was abnormal. And so after about the 3rd visit, they finally transferred Harlow to our service, the internal medicine service. And so we ran blood work on this dog. And again, there's a lot of non-specific findings. And when we saw him, he did have pneumonia. So his increased white blood cells, hard to know what that is due to because he was at that time had an active infection. But when we looked at his blood work, his sodium, perfectly normal, and not just within the range, right in the middle of the range. Same with his potassium. And so this was a dog in which the electrolytes were very normal. There were some other changes though. And ultimately we did test this dog for Addison's. And this kind of goes back to Lori's question. Not only did this dog have no cortisol, this dog had no aldosterone either. And so again, we see these types of cases. And so if we go back at Harlow, what alerted us? Well, clearly it wasn't electrolyte abnormalities. It was things like his proteins were low. His glucose was a little bit low. Cortisol helps to regulate glucose levels. His cholesterol was also low. And so these are the types of cases that we see getting missed all the time. So we'll capture them here, but these are the cases that, Addison's disease usually isn't on everybody's radar. And so, this would be a dog that technically has what's called atypical Addison's disease, but in our experience, these are dogs that are maybe atypical because their electrolytes are abnormal, but the majority of them are also deficient in aldosterone. So at least from that standpoint, from a hormonal standpoint, they're usually not that atypical. Now we see some dogs in which their aldosterones are normal and we see it go in both directions. But again, these are 3 different Addisonian cases with 3 vastly different clinical presentations. And that's often what we see. And so again, as many of you mentioned, how do you raise awareness of the disease? And so we have sort of our key criteria that we look at. But again, it's very heterogeneous. Yes, Lori.
Just a question for Harlow. Because Harlow had normal electrolytes but had no aldosterone, did you then treat with DOCP?
So that's a great question. It's really debated in the endocrine world whether you should or should not. So some of the dogs that do not have normal electrolytes, that do have normal electrolytes, they will remain normal for years. But there's also some of those dogs that will go on and develop electrolyte abnormalities. In our case, 2 weeks later, Harlow developed a low sodium. So from us, it was very easy to justify treatment. But in the cases that have normal electrolytes that do not have aldosterone, we generally treat, but we treat with a very, very low dose of DOCP. And our reasoning is twofold. One is they don't have any aldosterone. So in our minds, we're worried that some of those dogs may be a ticking time bomb. And the other thing that worries us is that we have seen some of those dogs, just like Harlow, that go on to develop electrolyte abnormalities. Now, the other side of the argument is, well, there's certainly well-documented instances in which these dogs never develop electrolyte abnormalities. But from my standpoint, I feel I sleep better at night knowing that they at least have a little bit of DOCP on board versus worrying, are they going to come in and crash one day if they happen to get into the trash and eat something that they shouldn't have, and they start to vomit and have diarrhea, and then they have no aldosterone on top of that, maybe they're going to get really, really sick. So we usually do treat, but there are certainly institutional differences in how they approach that.
Great, thank you. I'm going to mute myself because my dog is barking again.
Yeah, no worries. So I think from my standpoint, again, I think the awareness is a big thing, and we catch the cases that slip through the cracks, I think, or at least I hope we do. We probably miss some ourselves as well, but I think you have to look for Addison's disease and not just wait for the acute hypovolemic shocky dog to present through the doors. So, and I guess, I don't know if you all have any questions about that, and then we can certainly talk about diagnostics and some of the things that we've done as well, Lori.
Right, so I think this is where we move into the diagnosis and including possible alternative options. So I'll let you run with that so that I can mute so you don't have to listen to my dog.
Yeah, no worries. And for anybody that listening in, feel free to use the chat. I'm happy to stop at any point to answer any questions, so don't hesitate to ask. As most of you know, if you have an Addisonian dog, I imagine that dog was diagnosed with Addison's based on the results of an ACTH stimulation test. And the test is great because it's extremely accurate. It's usually not at all equivocal. The results are usually polarizing. Dogs that don't have Addison's usually have very normal to even exaggerated responses. Their cortisols are usually very high. Dogs that have Addison's have very low cortisol concentrations at your baseline sample. Even when you try to stimulate them with the synthetic ACTH, they fail to mount a response to that. But the downside is that it is expensive. I think most of you probably paid somewhere between $200 and $250 to do the testing. There's also a lot of clinicians that don't carry or don't stock the synthetic ACTH that's used in testing. And so, a recent trend in the last 5 years is looking for, what other test options can we do? And there are some that have value, some that don't. A lot of things have been looked at from this standpoint. The one thing that we do know, though, is that using the routine laboratory parameters, in other words, a sodium to potassium ratio, lymphocyte counts, neutrophil counts, any of those parameters are just not that accurate. And there's a number of studies showing that. And perhaps this figure is probably beyond the scope of this. But the bottom line is, if the results of a perfect test hug this Y and X axis, the little blue squares or the ACTH stimulation test, you can see that all of these other blood work parameters are not hugging those axes. Basically, they are not a completely accurate test. And I think that makes sense because we know that 20% of dogs with Addison's disease, at least, do not have electrolyte abnormalities. So certainly relying on those are not going to be valid. But we also know that other diseases can cause similar abnormalities as well. And so again, the routine lab work is giving us clues, but it's not enough in and of itself to really establish a diagnosis. So one thing that we did a few years back is we looked at what was the value of just that initial resting cortisol. So not doing the full ACTH stimulation test, but really looking at the baseline, just single unstimulated cortisol measurements have value. And what this figure is showing are the results of cortisol concentrations in 163 dogs with Addison. So it looks kind of like a weird finger, but those are all dots that are superimposed on each other, versus nearly 400 dogs that were suspected to have Addison's, but did not have Addison's. And so you can obviously see in the dog group, the Addison's group, cortisol concentrations are virtually nothing at baseline, and they're virtually nothing after stimulation. However, dogs with non-adrenal illness, so dogs that are suspected to have Addison's disease that might not necessarily have Addison's disease, occasionally their cortisol concentrations drop down because they fluctuate throughout the day, and they can overlap with some of those basal cortisol concentrations in dogs with Addison's disease. But what it does highlight is once you start getting cortisol levels above a certain threshold, you feel really good about excluding Addison's disease. And so I think one of the things that we were really able to establish is that if you measure a baseline cortisol and your results are, in our lab, we measure everything in international units, so nanomoles per liter. Some of you might be more familiar with micrograms per deciliter. But basically, if you have a result that is in the 40 to 55 range using the international scale, which that equates to about 1.8 to 2 using some of the other common commercial scales, you can feel virtually 100% confident that that dog does not have Addison's disease. And so that's something that is extremely useful when we're screening some of these dogs for disease and we're trying to save a little bit of money or we're trying to get a quick turnaround result. We use basal cortisol concentrations all the time. In fact, we had to pull the numbers last year, and we tested 600 dogs with a baseline cortisol concentration. So we do a lot of disease screening. Again, we can't necessarily confirm disease with some of these values, but it's a great screening test. Whereas if we have a result above that threshold, we can confidently say that that dog does not have Addison's disease. So that's one of the things that we did several years ago. That's now pretty common practice, I think, with many veterinarians. Some aren't doing this, but many are these days.
It's very interesting. And we occasionally, on the ACTH test, they have, like, if it's less than 2, I'm used to the other measurement, less than 2 or less than 55, it's Addison's. But then there's this gray area where they say it's Addison's on the test results, but it's really not. And we do see dogs who are diagnosed with Addison's who have their cortisol is above 55 or above 2. And we have to say to the people, you might want to check on that.
Yeah, absolutely. And we've seen a lot of the mistakes that we see are perhaps the ACTH product was expired or not stored appropriately, and so they don't actually generate the fully robust response to it. The other thing that we see a lot of is that dogs were receiving steroids and they didn't realize the dog was receiving steroids. And that seems, well, that should be obvious, but there are so many ear medications, eye medications, skin medications that contain steroids in them. And it only takes a few doses to suppress the responsiveness of those adrenal glands. And so many of those dogs that have equivocal results, we recommend, we make sure they're not receiving any drugs, and then we retest again 3 to 4 weeks later in most of those cases.
And so if a dog has been on any kind of steroids, even if it's a small amount, do you wait 3 or 4 weeks or no? Or
so it's tricky. And I think it's hard to give a blanket answer. What we do know is that dogs that are given steroids for about a month take at least 1 month to recover. So what we don't know, though, is, well, what about the dogs that were treated for just 4 or 5 days? How long do they take to recover? Probably not a month, but we don't know that for sure. Now, the other thing, though, that we do know is that it does only take about 4 or 5 doses, even really low doses, to suppress that, what we call the hypothalamic pituitary adrenal axis. And so if you give a dog steroids for 4 to 5 days in a row, even a very low dose, even topical steroids, ear medications, eye medications, and you were to do an ACTH stimulation test after that time, many of those dogs would look like an Addisonian on an ACTH stimulation test. And the reason, because most dogs only have really low levels of cortisol over time. So even though the doses that some of those topical medications confer to them systemically is really low, it's still enough to suppress their adrenal glands. And so So I can't give you the definitive answer other than it only takes a few doses. And we usually feel good trying to wait 3 to 4 weeks after stopping those before retesting.
Thank you. That's very helpful.
So another thing that one of my friends at Mississippi State did, Dr. Patty Lathan, I don't know if you guys have come across her work at all or worked with her, but to the same end, looking for ways to diagnose Addison's disease in which you can bypass the ACTH stimulation test. And so what she actually did is she studied looking at the cortisol to ACTH ratio. So it would be a single blood-based test. And if you think about the physiology of Addison's disease, normally it's the pituitary gland that's producing that ACTH, which is telling the adrenal glands to make cortisol. So if the adrenal glands aren't making cortisol, the ACTH or the pituitary gland thinks that they just have to send a stronger signal. So they'll secrete more and more and more ACTH. And so what she looked at was, can we look at the cortisol to ACTH ratio? And this is a group of dogs with Addison's disease. This line in the middle is sort of the median, or where most dogs were clustering around. And these are healthy dogs and dogs that had other illnesses that were thought to be Addison's disease. And you can see this actually looks like it's a pretty good test for Addison's disease as well, which also is able to, again, bypass the need for cosentropin. The problem is that most labs are not measuring endogenous ACTH. Our endocrine lab does, so we actually can do this test, but there's a lot of laboratories that don't do this. And so, but again, I think depending upon veterinarian comfort, their comfort level, which labs they're using, this is something that might be an alternative too, that not many people are doing, but it has been studied, it has been looked at. Again, I think the thing that maybe limits it a little bit is measuring that ACTH in blood. So something that our group did recently, and we just published this study, probably published a couple of weeks ago, actually, I think, is that, we know that most of these dogs don't have aldosterone. And so it's that aldosterone deficiency that results in the low sodium and the high potassium in many of these dogs. And the reason it does that is because of its effects in the kidney. So it results in sodium losses through the kidney and an inability to get rid of potassium. So in theory, a dog with Addison's disease will have a lot of sodium in their urine, but not much potassium. And that's the opposite of what it would be in a normal, healthy individual. And so we actually looked at, could we look at urine electrolytes to try to help aid diagnosis? This would avoid the need for any hormonal measurements. And we certainly found differences. The dogs with Addison's did have what really low, the healthy dogs had really low amounts of sodium in their urine and lots of potassium in their urine, which was different than dogs with Addison's disease. But each of these dots represents individual animals. And you can see there's just too much overlap for it to be a great test. So we spent a lot of time getting urine samples from all of these Addisonian dogs. And yes, there's certainly differences between dogs with Addison's and dogs that don't have Addison's, but not enough that it allows us to comfortably diagnose the disease. But that made us think, well, is there anything else we could do with urine? And I think the answer to that is probably so. So one thing that we started to look at were urinary cortisols. The main limitation of measuring cortisol in blood is that cortisol concentrations fluctuate throughout time. And so that's why a low cortisol in the blood can't be used to confirm a diagnosis of Addison's disease, because dogs without Addison's will also have cortisol levels that drop and increase throughout the course of the day. But if we looked at cortisol in urine, that really would reflect cortisol over several hours, right? Basically, since the last time the dog urinated, the amount of cortisol in that urine would sort of give us an idea of what has happened with cortisol levels over that period of time. And so we actually measured urinary cortisol to creatinine ratios. We compared to creatinine to offset the effects of how much water the dog's drinking and other factors like that. But basically, we looked at urinary cortisols and found that in dogs with Addison's disease, most of them had none. It was usually 0. And dogs with other illnesses had much, much greater amounts of urinary cortisol. And so we haven't published this study yet, but and we have more animals now, but I do think that this is certainly something that may gain traction in the upcoming years, as a way to help aid in the diagnosis of Addison's. Obviously, we need some more animals, but I think it's a really promising test, at least based on the numbers we've looked at so far.
That's very interesting. And how much is this test compared to the ACTH test?
Yeah, so this test, for our clients, they pay about $60 for a urinary cortisol to creatinine ratio. So I think different labs will charge different amounts, but our laboratory charges $35 for the test. So our markup to clients is about $60 or $65. So it's not, no matter which way you look at it, it's far less expensive than the ACTH stim.
Right. And do most vets or hospitals have this test available?
So most of them don't have the ability to measure it in-house, but almost all of the commercial laboratories, IDEX, Antech, HESCA, most of them are offering this measurement as a send-out test now. So it's not one that's difficult to have performed in dogs.
That's great.
So I think those are kind of, from a diagnostic summary. Of course, the ACTH is still the gold standard, but I think there's an underutilized role of those baseline blood cortisol concentrations, which can really be helpful for screening. And then I think we're moving to perhaps being able to start utilizing the urine cortisol to creatinine ratio in some cases as well. And we're continuing to study that, and we're hoping to get that published later this year. But it takes a while to get these things into an actual journal. The review process is often several months. So hopefully we'll have that out pretty soon as well.
And I see a question from Mary. Does it matter what time of day the urine is taken from?
So that's a great question. And so the urine cortisol to creatinine ratio test, the reason that's even marketed is to screen dogs for Cushing's disease. And in doing, so the opposite of Addison's, obviously, so dogs with excess cortisol production. And in those dogs, the timing matters and the method of collection matters. So we don't collect them in hospital because just the stress of doing it in hospital might cause an increased result. Similarly, we usually recommend first morning collections. However, for Addison's disease, it doesn't matter because that dog with Addison's is never going to be able to mount a response no matter what we do. So the method of collection and the timing of collection for Addison's disease is far less important than when we're using that test to evaluate for Cushing's disease.
So another question, this is from Donna, is does the dog need to be off pred to do this test? I think the test would be done before they were put on pred, but if they were on pred.
Unfortunately, pred would absolutely interfere with this test, just like it would with the other tests as well. And so the assays that we have to measure cortisol in urine, a lot of those orally administered steroids, they'll break down into various corticosteroid products, and they will be detected on the assay. So yeah, so any steroid could interfere with this testing, similar to with the other blood-based test.
So one of the things that you're triggering in my mind for this, both your earlier comments and this, we have limited funding, but we are able to sometimes help people to, especially dogs who are at risk of dying, to get treatment when they're in an Addisonian crisis. For some of them, I mean, you gave the numbers of $200 to $250 for an ACTH test. We've heard up to $500, and that's just really expensive. So some of these dogs, the vet is comfortable with what we call the Docp test, which is looking at those values that you showed earlier. And you showed that dog that really looked like, hey, this is an Addisonian dog. This dog must have Addison's, and you saw that the dog really didn't have Addison's. That's very concerning to us because sometimes that Docp test is used, but using the UCCR would be much more affordable.
Yep, absolutely. And actually, I'm going to go back. I'm going to show you. So the other thing that I didn't really get into because there's a little bit of depth to it, but I can kind of walk you through it. So in those cases, if you actually look, most dogs that are sick have really high baseline cortisols. In fact, if you look at that, what we call the scatter plot, you can see that a lot of these dogs, their cortisol is really high. And so
your body's trying to compensate for the stress.
Exactly. And so if you were to take that really, really sick dog and the baseline cortisol was less than 5.5 on our scale, which would be 0.1 on the IDEX or Antech or the other scales that are out there, and you look at the specificity, i.e., how likely is that test to confirm a diagnosis, it's actually really good, 99%. And so, I think numbers are numbers and cut points are cut points, and it all depends on where you draw the line. But if you did have an owner that had no funds and they had a really, really sick dog, classic electrolyte abnormalities, and their cortisol was 0, yeah, is that the perfect approach? Absolutely not. But I would argue that it's a reasonable approach given the scenario, because the case that I showed you in which the dog didn't have Addison's, his cortisol wasn't 0, his baseline. I'll have to go back and find him. His cortisol was, I believe, it wasn't super high as I actually would have thought it would have been, but it was still 48. It was still much higher than a cortisol of 0 or a really, really low number. And so I do think that, so I agree with you that in some of those cases, you have to do the best that you can with those situations. We unfortunately didn't have a urine cortisol to creatinine ratio in that dog, but again, my guess would have been, it would have been really low in the Addisonian and probably pretty high in the dog that was not an Addisonian.
Very interesting. Trish has a question that I think takes us a little bit off topic, but if we could maybe address that quickly. How frequently is esophageal dysmotility present in Addison's dogs, or to go on to develop?
Yeah, good question. So from our standpoint, it's pretty rare. We see it in about 1% of the dogs that we diagnose with Addison's disease. And many times veterinarians, if they have a dog with esophageal dysmotility, they'll test for Addison's. And that's a reasonable thing to do. We do it as well. But in our experience, the dogs that test positive for Addison's, usually the esophageal, not even want to say usually, I'd say almost always, the esophageal dysmotility is not the only sign of Addison's disease. Usually there's some other features in those cases that would make us concerned that there's Addison's disease. It might not be the electrolytes. Maybe they don't have a stress leukogram. Maybe their glucose is low or their cholesterol is low. But usually in those cases with esophageal dysmotility, there's other laboratory features that would at least raise concern for Addison's disease. So it's rare, but it does happen. Once dogs are treated, it typically has resolved in our experience, and we usually don't see it develop in dogs once they have been treated. So if the dog's being treated, it would be exceedingly uncommon for the dog to develop it because of Addison's, unless they weren't being appropriately treated.
Interesting, thank you. Are we ready to move on to the long-term management, or did you have more on this?
No, I think that's, I think we can certainly move on to that.
Okay, and in the course of talking about this larger topic, you will also cover your research on low-dose DOCP, correct?
Yeah, and I'll kind of jump ahead just to leave some time as well. And so
you don't have to jump ahead. Well, maybe you do. It's 2:42. I'll let you decide how quickly to go through.
Okay, and I'll at least touch upon some of these. And so, one thing that the number one reasons that we see for treatment failure are that owners stop giving pred or whatever glucocorticoid they're using. And I know why it happens. It's because dogs that are treated will sometimes develop signs of pred excess. And what we've really discovered is that most dogs only need a very, very small amount of pred. And the problem is that I think a lot of dogs are placed on much higher doses that they need. And owners get tired of dealing with the drinking, the urination, the ravenous appetite, the skin changes, and they end up just stopping it. And there are some dogs who will actually do remarkably well on no prednisone for a long, long time, but many of them will develop illness at some point. So it might not happen right away, but they usually will. And so I think from our standpoint, the dogs that we see that struggle are usually the ones that aren't getting any prednisone. But again, the amount they need, at least in our experience, is usually a really small amount. And so, one of our solutions is not to stop the pred, it's just to simply give less and to recognize that these dogs don't always need what we classically consider to be a physiologic dose.
And we talk about this all the time in our Facebook group because the dogs are having unbelievable symptoms. We've seen dogs being sent home on 1 full mg per kg of pred, which boggles my mind. But what we find is even lower than so there was a quote from Dr. Deborah Greco in a in a roundtable, Addison's roundtable, and she said she gives as little pred as possible, and such she might go as low as 1 milligram for a 100-pound dog. And we actually find that to be a pretty good estimate. So we've done surveys in which we find that many of our dogs are on 0.02 to 0.04 or 0.05 mg per kg. And they're doing great. You know, some need more, some actually need less. But yeah,
absolutely. I would agree. And I think part of the problem too is that we assume that dogs absorb and metabolize drugs all the same. And they don't. If you were to ever go actually look at a pharmacokinetic study for any drug, an antibiotic, steroid, any drug, there's so much variability between dogs and among dogs. And so I think that's part of the problem. In humans, they actually monitor endogenous ACTH levels. And so as I kind of mentioned earlier, that in dogs with Addison's, untreated Addison's, their ACTH levels are through the roof high because their pituitary gland is trying to tell that adrenal gland to make more. And so we have had the occasional owners where they're so scared to lower their dose of pred because their vet told them not to do it or something along those lines. And so we say, okay, well, we'll prove it to you. We're going to measure endogenous ACTH concentrations in your dog, and I bet they're going to come back as 0, which means you're giving too much pred. And so certainly there are some ways we can further support the adequacy of it. But I agree, usually we're basing it on clinical signs. We keep giving them lower and lower to make sure they have no signs of Cushing's or excess. And once we reach that point, we usually feel pretty good. And it is a balance between, you don't want to go too low and you don't want too high, but a 1/4 mg per kg, which is considered the classic physiologic dose, is too high for the majority of dogs. And that is 100% true for medium and large breed dogs. Some of the really tiny dogs don't seem to care if you give them that much, but the medium and large breed dogs, that's a lot of pred for the long term.
Great, thank you.
So I think to kind of probably touch upon some of the stuff that we've done and to get into that, I know that, you know, it seems like most people here are using DOCP. Maybe there's a few fludrocortisone users as well. I'll kind of skip through that. I think most of us as veterinarians, or at least internists that deal with a lot of Addisonians, we like DOCP because we like to be able to titrate our doses for each hormonal deficiency as individual problems. And so that's why I like it. But that's not to say that you can't successfully manage dogs on 4NF, because you absolutely can do it that way. But as most of you probably know, the issues with DOCP relate to cost, right? And so if you were to use the label doses of DOCP, the 9 kilogram Westie's probably costing about $600 a year, but the 60 kilogram St. Bernard is costing thousands of dollars every year to treat. Once you factor in monitoring visits and lifetime costs, it's a really, really expensive disease to treat. You all know that. That's nothing new. But if you look at the 2 products out there, some of you probably are still using Procordin. Some of you are probably using Sticortol because Procordin went on back order a while back. There's 2 real strategies to go about it, either decreasing the dose or increasing the interval. And perhaps some of you are doing a combination of both. Perhaps you're doing one or the other, or perhaps you're not doing either. But I have concerns with the interval prolongation strategy for a few reasons. And one of the reasons is that there's only one study published on it. And it suggested that the median dosing interval, so the sort of middle point for dogs, was around 2 months. So that study suggested that dogs only needed DOCP roughly once every 2 months. However, if you read the study really closely, only 15 of 53 dogs in that study actually completed all 3 study phases. It took about 6 recheck appointments to actually determine what the dosing interval is. And so if you're trying to save money, you have to go to the veterinarian 6 times within 2 months and pay for blood work every single time. That's not really saving much money. The other problem with that strategy is that some of those dogs that had a really extended interval prolongations actually got sick, likely because they ran out of their DOCP or their DOCP effects wore off before they went back into their next evaluation. And so from my standpoint, I've never been a fan of interval prolongations. Now, I will occasionally do it in select cases, but in general, that's not my preferred approach. And so as we kind of hinted at earlier, we've been using lower starting dosages at MSU for decades. we seldom, if ever, give more than 2 milliliters, which is, half a vial for any dog. Even the dogs that are giant, the 60-kilogram dogs, we're rarely ever giving more. And we're usually starting at these lower dosages as well. And the benefit is that for medium and large breed dogs, you're cutting their lifetime treatment cost in half right off the bat. The other thing that you're avoiding is that if you follow the label guidelines, they suggest that you do this in a very incremental fashion by changing the dose by about 0.1 to 0.2 mg per kg every month. So it would take you over a year and 12 laboratory evaluations to even get to some of the lower dosages that we're just routinely starting dogs on. The other thing that I think is commonly ignored and overlooked is that a lot of these label dose protocols are resulting in excess treatment with DOCP, which is harder to quantify. And so the big study we did a couple of years ago that was just published this past year is we actually did a randomized controlled clinical trial where we looked at dogs and we divided them into 2 groups. These are all true Addisonians that had electrolyte abnormalities needing DOCP treatment. And we divided them randomly into 2 populations. So dogs that received 1.1 milligram per kilogram or half the label dose, and dogs that received the standard label dose. And you can see that our populations at baseline were virtually the same. These were all very similar populations of dogs. Everybody was blinded to treatment group. Every dog was randomized. So the owners didn't know what dose of DOCP the dog was receiving. We didn't know what dose of DOCP the dog was receiving. And we basically rechecked them at 10 to 14 days after each injection and at roughly 30 days after each injection, which is the time when we were then giving them their next injection. And so you can see that if we looked at sodium to potassium ratio in these dogs over the 3-month time period, so this is where they started. Again, they all started very low as would be expected. You can actually see that the low dose DOCP does a really nice job of controlling the electrolyte abnormalities. And in fact, probably restores most of these dogs to closer than normal than what the label dose does, which is actually pushing some of these dogs probably over treatment. This was actually looking at urine specific gravity, which is a marker for urine concentration. And one thing that you can see is that at the end of the study, the urine specific gravity in the dogs that were treated with the label dose, the higher dose, was significantly less than the urine concentration in dogs that were treated with the low dose. And what this probably means is that, so these dogs that are being treated with more DOCP, they're more likely to have increased drinking and urination that is not normal. And I think many people always want to attribute that to being a prednisone effect, but in some of these dogs, it can be a DOCP effect. And the reason that that happens is that excess DOCP will actually expand the blood volume and renal blood flow, which is going to result in increased urination and hence increased drinking. And so I think this was a really important finding as well, once again, suggesting that the label dose is more than what the vast majority of dogs need, and half the label dose is probably more appropriate for many of these animals. These are graphs showing the sodium and potassium concentrations. Again, the gray values are the dogs that were treated with 2.2 mg per kg. The black dots or triangles are the dogs that were treated with half of that. And again, you can see that where the averages are, the medians are, they're probably more closely approximating the middle of those reference intervals in the dogs that are being treated with low dose DOCP. And so we also looked at another marker. I'm looking to see what time it is, yet we have a few minutes left. We also looked at plasma renin activity, and most of you are probably not familiar with that measurement. But basically, aldosterone release is stimulated by 2 major factors: the potassium concentration and activation of the renin, angiotensin, aldosterone system. So there's 2 different forces that can stimulate aldosterone release. And obviously, when we're giving these dogs DOCP, we're treating their aldosterone deficiency. DOCP is just our synthetic version of aldosterone. And so in dogs that do not have any aldosterone, their plasma renin activity is really, really high because the plasma renin is trying to tell those adrenal glands to make more aldosterone. And so in dogs with newly diagnosed Addison's disease, their plasma renin activities are through the roof. Now, similarly, if we're giving dogs too much aldosterone, that's going to shut off their renin production, and their renin would be really, really low. And so I thought one thing that was really interesting in our study is that virtually every dog treated with the label dose DOCP was likely overtreated based on our measurements of plasma renin activity. And so you can see that 16 of the 17 dogs that were treated with label dose had plasma renin activity that was so low, it was lower than what our assay could even measure, meaning they were being overtreated with DOCP during that study. And so I think that from our standpoint, one of the biggest findings from that study is that not only does low dose DOCP help to address the cost concerns, it's probably the more physiologically and biologically appropriate way to treat these dogs with Addison's disease. And so that was probably one of our bigger studies in recent years. I know Lori's obviously seen it as well. So any questions about that? I think there's maybe a couple in the chat.
One of the things that I did want to mention is, and your slides are amazing. We love the cost savings of low dose DOCP, but the reason why we advocate for it so much is the dogs seem to feel a lot better. And your slides have just shown us that they do appear even, I don't know if healthier is the right word, but they do better with less.
Yeah, 100% agree. And the problem is it's so hard to quantify what are the clinical signs of a little bit too much, because there are cats who develop adrenal tumors that secrete too much aldosterone. They develop all of these crazy blood work abnormalities. But the abnormalities that we're probably seeing with too much DOCP are going to be mild. So you're not going to see those classic things. But I do think in general that, yeah, we absolutely do see some of these dogs who just, maybe they have a headache, but how does a dog tell you they have a headache? Maybe their blood volume's a little bit too expanded, but how are you going to detect that as a clinician? So I think a lot of those things are really hard to quantify in studies, but in the clinical setting, I absolutely agree that not only is it just lab parameters, I do think the dogs are usually doing better. Now, I don't want to say that every dog can be treated with the same dose of DOCP. There's a lot of differences too. Smaller dogs are different than bigger dogs. Younger dogs are probably different than older dogs. There's a lot of biologic factors that go into it. But in general, our experience would strongly support that much lower doses are ideal for the majority of dogs with Addison's disease.
Right. And we do take into consideration that we do try and look at each dog as an individual, and they have their different needs. I've had many Addisonian dogs because I adopt them. And I was always surprised at, like, hey, this 65-pound dog needs this dose and the other 65-pound dog needs a very different dose. And it's just really important to individualize it, as you've mentioned. I think we've covered the questions so far in chat. I did have another question, both in your study and also in your slides here. You mentioned that the study did the half label dose of 1.1 mg per kg. But really, you're seeing much less than that given, and dogs do well.
Yes, so I can share my anecdotal opinions on some of that, so I can't say they're fact. For the study, we just chose 2 doses because that's how we needed to design the study. We needed all dogs to either be in one group or the other group, and so we didn't try to, manipulate the doses throughout the study. But in giant breed dogs, medium to giant breed dogs, our experience is that they can get by usually with less than 1 mg per kg. Many of them can. In fact, some of them are down to around a half a mg per kg in that dosing range. And I think one of the comments in the chat was probably in that general realm as well, which is what their dog is. It was a Labrador or something when we look back.
Yeah, you're talking about Luke.
70-pound dog. Yeah, exactly. A 70-pound dog getting a very, very small amount of.
And gets 0.35 mils of Zycortal monthly.
And so we do see the outliers. Now, I think we have to be careful with that, because what we're basing this on is normal electrolyte levels. And in humans, that's only one piece of the puzzle. Plasma renin activity is the other big piece of the puzzle too. And as I highlighted, just because a dog has normal electrolytes doesn't necessarily mean that they have normal amounts of aldosterone on board, right? We showed that example of the Great Dane that clearly had no aldosterone, but yet his electrolytes were normal. And so I do think we have to be a little bit careful with how low we're going. I do think that very, very young dogs and some of the small breed dogs, in our experience, tend to need more DOCP on a mg per kg basis than do the medium and large breed dogs. So for some of the really small dogs, maybe we start them on 1 or 1.5 mg per kg at their initial dose. And if they look good at their recheck, then maybe we try to drop them to 1. But in our experience, it is exceedingly rare that a medium or large breed dog needs anywhere close to the label dose. And then it's even uncommon in the small breed dogs. But again, the small breed dogs tend to need a little bit more than the large breed dogs on a mg per kg basis.
Very interesting. Do you have a hard stop at 3 o'clock? Because it is 3 o'clock.
No, I can hang out for a few more minutes.
Okay, great. A couple questions in the chat. So, and one other that I wanted to ask you, just we see many vets who are afraid, or whatever the emotion is, they don't want to do this. They want to stick with the label. Is there anything, I mean, do you feel comfortable if they came to you, do you feel comfortable advocating for what you've discussed here today?
You know, I do. And I think, so our study is published now, and it's in the Journal of Veterinary Internal Medicine, which is an open access journal. So anybody can now access this. And so that's my hope, is that, you know, this was only, was officially published probably about 6 or 7 months ago. And so my hope is that now more veterinarians will see it and feel more comfortable with it. What I do tell some veterinarians who feel very scared of doing it, and I do think, and one thing we did show in our study that we didn't talk about, is that when dogs leave the hospital, their total sodium balance is not normal yet. It takes some time. And so if veterinarians are really worried and they don't want to do the low dose, fine, maybe go ahead and give your 2 mg per kg dose if that's what you want to do for the initial dose. But at your next dose, you should cut it in half. You do not need to do this gradual reduction by 0.1 or 0.2 every month for, you know, a year and a half. Just go ahead and make the jump, because otherwise you're going to be playing with this for a long, long time. And so the ones that are really uncomfortable doing it, I do say, fine, go ahead and give that, you know, close to label dose if that's what you're most comfortable with at the first injection. But when you see that dog back in a month, go ahead and cut the dose in half for the majority of these dogs.
Okay, well, you just answered Louise's question. Thank you for that. We do see some vets who want to do it like 10% at a time, and we're like, that's going to take forever.
Yep, exactly. And you know, and they are following label guidelines. And so I think there's probably some, you know, that factors into their decisions a lot as well. It looks like, you know, one question was, as dogs get older, do they need a higher dose of DOCP? What I can say is that dogs that are getting fludrocortisone, that does tend to be true. We often see them needing more fludrocortisone. As dogs get older, we have not typically seen them need more DOCP unless A, their body weight changes, their muscle mass substantially changes, or they develop concurrent illnesses. Dogs that go on to develop kidney disease and heart disease later on down the road, their responsiveness to DOCP tends to change in our experience. And so those are the ones that tend to need adjustments. But I think most dogs end up doing okay on a relatively static dose unless one of those other things happen. So again, body condition changes, or they develop some other conditions that probably alter kidney blood flow, basically.
And we have seen that side. We've also seen the opposite, where they suddenly need a lot less. They've been on one dose for years, and then they start to need less, which is very odd. But we see it.
And I think, so the other things that go into it too, are there dietary changes? Are there lifestyle changes that go along with these? Because another thing, you know, if that dog were to eat a banana every single day, probably not going to, it's going to probably need more DOCP than the other dog. And so changes in diet can really drastically change sodium and potassium loads as well, and can certainly also influence dosing as well. We would love to look at that, but it would be so hard to look at the dietary aspect as well.
Right. Exactly. Trish asked, are there outward signs that one can see in their dog as to when they need their DOCP, like whitish nose, rough texture to neck?
So I think by the time they show outward clinical signs, we've waited way too long is the problem. And so I think that in an ideal world, plasma renin activity assays would be widely available. And then you could titrate your dog's dosage based off of the electrolytes and plasma renin activity and blood pressure, doing all three. And you could probably find the perfect dosing interval. The problem is that we do a terrible job of checking blood pressures in dogs. And part of that is it's the fault of the dog, right? They get nervous and stressed, and getting an accurate reading can be really hard. And plasma renin activity can seldom be done outside of research settings. And so I think, we're largely reliant upon electrolytes, but I don't feel comfortable waiting for signs to develop, because my fear is that if they have those signs develop, who knows what is going to be the next clinical sign for that dog. So I do worry about waiting for signs to emerge, so to speak.
So one thing that we find a lot is, even for dogs who've been started on the low dose, their potassium is still pretty low at 28 to 30 days. So we wonder, for those dogs, do you delay until the potassium comes up to at least mid-range before giving the next one? That involves more testing, but.
Yeah, so I think it's tough. Most owners just want to give DOCP once a month, right? Like that's what I would do for my dog, just so it's easy to remember. I've got it on the calendar for every day. So I guess to answer that question, I would assume that if their potassium was low at day 28, it was probably low at day 14, whether it was measured or not. And so from my standpoint, what I will typically tell owners is that, well, we're going to go ahead and retreat today anyway, that we don't have to come back in again in 3 days and then 5 days, but we're giving a lower dose. If your potassium's low on day 28, then the dose that we gave last time was more than what your dog needed. And it would be really unusual for that repeat dose at day 28, unless the potassium was substantially low, to result in a clinically relevant problem, especially if you're giving a lower dose that injection. But we offer it both ways. It's just in our experience, most owners don't want to say, oh, you mean it's Friday now and I've got to come back in next Tuesday and do blood work again. We'll usually just drop the dose a little bit at that time and retreat.
So it's for convenience mostly and cost savings. Question from Mary: do you think the manufacturers will ever change their recommendations for initial doses?
I know some of the people at DECRA, and I like them, and they're good scientists. I don't know. They actually emailed us and congratulated us on the study, which they could have said we hate this study, but they were very professional about it. And obviously, we're basically suggesting that we use half of their product. So I don't know. I think that maybe the initial dose recommendation might change, but it might not change. But my hope is that they're going to reconsider their guidelines for how we alter the dose. Because I think that, the single dose at 2.2 mg per kg, I agree, it's too much, but I could live with that if there was some other recommendation to suggest a much more rapid dose reduction protocol in these dogs, so that people aren't trying to lower the dose over a year and a half, or they're not over treating their dog for a year and a half during that time. But I have no idea. It's obviously a dollars and cents thing for the manufacturers.
Right. Do you have any understanding of why Zycortal stings and Procortin doesn't?
It's a great question. We had one dog in our study who cried out every single time the dog got Zycortal, but the other 36 dogs were fine. And we've seen a couple of dogs outside of the study. It is a different carrier suspension in there. And so we think that's probably why, but it seems to, at least in our experience, we do think it's real. We do see dogs that it happens to, but it does still tend to be pretty uncommon in our experience. But I don't know what specifically it is that triggers it for some dogs, but not for the vast majority of others.
We see it a lot, just because we have thousands of people in our group, but we do see it a lot. And for those people, when Procortin's available, some of them can switch to Procortin. Some of them live in other countries where Procortin is not available. So it is unfortunate. Question from Anne is about stability studies. How long can we count on the vial of DOCP being good to use?
So the issue is probably not with stability as much as it is with needle going in and needle coming out multiple times. And so the DOCP molecule itself is really stable, but the the guidelines are really more in place because could there potentially be bacterial contamination? You know, we usually say 4 to 5 months is probably fine, but we don't know that for sure. We have owners that are giving really small amounts that'll keep the same vial for even longer, and we've not seen problems. As veterinarians, we don't necessarily feel 100% comfortable for advocating that because we're starting to deviate from guidelines. And if something did happen, we could potentially be held liable for it. So we don't like to deviate too much from it. But the molecule does tend to be stable for quite a lengthy time.
I had actually asked one of the veterinarians at Elanco about that, and she said that with a multi-dose vial, if nothing's written on it, then you have to assume that it expires in 28 days. But what they did was do stability studies, and they studied it up to 4 months. They just didn't study it longer than that.
Yeah.
But what you're suggesting is a bacterial contamination issue, which is different.
And I think, you know, to be honest, if you can make it 4 or 5 months with a vial, you're doing pretty good anyway, you know, and from a cost standpoint. So, you know, that would basically equate to giving, you know, a relatively small amount for many of those dogs. Now, again, for the small dogs, you're giving really, really small amounts to, you know, I get it. And most of our owners do keep the vial for longer than that if they can. We're just careful on what we advocate for.
Right. Let's do one last question, which is from a vet, from Cheryl. Do dogs have high blood pressure from high doses of DOCP or any long-term cardiac issues?
That's a great question. I suspect the answers to this are yes. We actually looked at blood pressure in our study, but as many of you probably know, we're often doing Doppler blood pressure measurements, and position, excitement, the hospital, all of those things influence it. And so we didn't find statistical differences, but the bottom line is we suck at taking blood pressure, and our patients are not always the most compliant. We had one of those dogs that came into the hospital that was ready to eat our heads off every 2 weeks. And so, you know, of course, every time we checked the blood pressure in that dog, it was 180. It was super high. And so I think that's probably true, but we don't have data to show that. And other studies of DOCP have suggested the same thing. We just don't know. In terms of cardiac disease in humans, one of the biggest concerns with long-term adrenal insufficiency patients is that there is a higher risk of cardiovascular related mortality down the road. We actually have a study trying to look at that now, because that would be one of the concerns with long-term overtreatment, is that maybe there is a higher degree of cardiac or kidney disease in dogs. The problem is that we just don't have the long-term studies in dogs to know whether or not that happens. I mean, maybe a dog that's overtreated lives for 5 years versus a dog that's not overtreated lives for 7 years. We just don't have that information yet, but we do have a couple members of our team that are actually studying that right now.
That's very interesting. One of the things we do surveys, you know, that talk about what the dogs are getting in terms of treatment. We have, I don't know, 200 or 300 or more dogs that are on 1 mg per kg or less. And that's not scientific. So, you know, I can't say to a vet, hey, look at our data, because it's not scientific. But anecdotally, we really do see dogs doing well on 1 mg per kg or less of DOCP. So it definitely is. And we were doing this, you know, long before there were any published studies. And thank goodness there are finally published studies. So thank you for that.
So I do think there's a lot of value in that. And you know, maybe we can regroup after this in a week or two and talk about it. But I mean, I think that, you know, long-term follow-up surveys and owner-based surveys are important. Now, as you mentioned, the limitation is, well, they're not necessarily a scientific study, but the way you overcome that is sort of power in numbers. And so if you have so many survey responses, you can start to see the trends. And even though you may not necessarily have all of the accompanying lab work or everything else that goes along with it, there are powers in numbers. So I mean, I do think there could be value in looking at some of that data as well.
Right. And in humans, they look at patient-reported outcomes. You can't do that in dogs, but you can do owner-reported outcomes.
Yeah, exactly. So I do think if you guys, you know, with that large of a group, we should certainly talk more about it, because I think there are some things that we could probably do, especially if you guys get pretty good response rates on the surveys as well.
That would be wonderful. I think I got all the questions. Debbie, yours is an individual one about Bismarck. Sometimes the syringe breaks, or when you give it the percortin or the Zycortal, like, squirts out and doesn't get into the dog. So we can talk about that, Debbie, afterwards. Any other questions before we thank Dr. Langlois and let him go?
Yeah, no.
People ask about added salt in diet.
Well, you know, before the days of DACP and fludrocortisone, humans would consume a ton of salt to deal with it. And in fact, when we're managing Addison's disease in the hospital, you know, we don't necessarily give them DACP on day 1. We're often giving it on day 2 or day 3. And honestly, it's their IV fluids that are giving them a ton of salt and a ton of volume. And so, yes, so I mean, dietary salt would presumably decrease the amount of fludrocortisone or DACP that the dog would need. But again, you know, titrating and then finding the exact amount and making sure it's always consistent on a day-to-day basis, you know, those things can be a little bit challenging. But I mean, salt was, I mean, for a long time, salt was a treatment for Addison's disease.
And I see that more with fludrocortisone, that if the potassium is normal, but the sodium is a little bit low, some vets will recommend adding salt to the diet, so you're not also adding more glucocorticoid by increasing the dose.
Yeah, exactly.
Yeah, this was fabulous and just so informative. Just trying to look at, okay, I think we got them all the questions. Thank you so much for doing this. We have it recorded. We will show many more people besides just the people who came today. So really, really very much appreciate your time.
Hey, you're very welcome. Thank you all very much. I was happy to do it. And it's always great to communicate with the community too. So I appreciate it.
Awesome.
Thank you.
I will follow up with you on the survey stuff.
Excellent. Yeah, I think that'll be fascinating.
Okay, thank you so
Bye,
much.
everyone.
Bye-bye. And if anyone else wants to hang out and talk, I will hang out for a while. My dog.
I thought it was amazing. I learned